Hello, welcome to your lecture on nursing management of labor and birth at risk. Now, some of this information we already reviewed in other lectures. If you're watching this one first, I recommend going back and watching some of the other lectures before you watch this one. But some of the information might be a little repetitive. So we talked a little bit about dystocia, and so again, these are things that may hold up labor. So some points here: epidural or excessive analgesia, multiple gestation, hydramnios, maternal exhaustion, ineffective maternal pushing technique, and occiput posterior position. So they usually have a longer first stage of labor. It takes them a long time. Nulliparity or short maternal stature. So again, this is the first time they're having a baby. The birth weight is over 8.8 pounds. There's a shoulder dystocia, so go back and listen to the shoulder dystocia lecture. Abnormal fetal presentation or position or fetal anomalies. And this could be things like a really large head due to hydrocephalus. Maternal age over 35 years. High caffeine intake. Now, moderate caffeine intake is okay in pregnancy, but I guess high amounts of caffeine can actually affect labor. Being overweight, gestational age over 41 weeks, chorioamnionitis, which is maternal infection, ineffective uterine contraction, and high fetal station at complete cervical dilation. This is kind of showing you a shoulder dystocia where they're doing McRoberts maneuver and suprapubic pressure. And I'm not going to go into this too much because it's in the shoulder dystocia lecture. Okay, we already talked in another lecture about powers with the problems with the P's. Okay, but we'll review the powers hypertonic uterine dysfunction. So this can be the uterus is just in a constant contraction state. Hypotonic, it's not contracting enough. Protracted disorders, things are taking much longer than anticipated as far as labor progress. Arrest disorder, so this can be arrest of dilation or arrest of descent. Okay, so either they stop dilating at a certain point or they're not reaching engagement, which is a zero station. Precipitous labor, or precipitate. This is where the baby delivers really super quickly. And it's a really fast thing. And it's still, even though it's quick, it's still kind of an abnormal type of labor. Problems with the passageway, pelvic contraction. We talked about pelvic types in the last lecture. And this is kind of where they have a narrow pelvis, or there can be obstructions in the maternal birth canal. I've seen women have a vaginal septum where they have two vaginas, two cervixes, two uterus. It's called a didelphys uterus. It can occur all the way through the tract or just maybe two uteruses and two cervixes. So, but anyway, a lot of these times, these things, the baby will deliver through and kind of push that septum out of the way. Sometimes they have like a polyp or something in their vagina. And so sometimes the baby will just kind of brush past it. But if it's a major obstruction, that can be a problem. Problems with the passengers, positioning, occiput posterior position. Remember we talked about this being a wider fit. It's just bigger than having an occiput anterior position, which is what is ideal. Breech presentation, which we're not going to deliver vaginally unless they're a frank breech and they come in with the butt presenting on the perineum. Multifetus pregnancy, macrosomia, and cephalopelvic disproportion, structural abnormalities, and then problems with the psych, so psychological distress. So I think I skipped it. Emotions such as fear, anxiety, and helplessness, being alone, and weariness can lead to psychological stress and directly causing dystocia. Sorry, I skipped too quick past the question. I can't go back. Okay, so nursing assessment and management. So we want to get a history of risk factors. Okay, maternal frame of mind, vital signs, uterine contractions, fetal heart rate, and fetal position. Okay, so those are all things that we're assessing initially when the patient presents. Nursing management, so we want to promote labor progress. Okay, those are things like positioning the patient, repositioning. Even with an epidural, you want to be moving that patient side to side, because if she's laying in one spot, the baby is not going to be able to pass. Doing things like placing a peanut ball. The peanut ball is great. It's like a yoga ball except a peanut shape, and we put that between the mom's legs so that the baby has room to come down. It causes the legs to not be so closed where she can allow the baby to descend. Providing physical and emotional comfort and promoting empowerment. Letting women know that they can do this. Regular contractions. Okay, so preterm labor. So these are contractions with cervical effacement dilation between 20 and 37 weeks. Okay, so 37 weeks is really the cutoff to determine, like, okay, this is preterm labor. And a lot of this comes from the fact that we can give steroids up to 36 weeks. Okay, but be aware that 37 weekers and even 38 weekers can have problems. Okay, they can have problems of prematurity. So sometimes lungs aren't fully developed. They can have feeding problems. They can have temperature problems. So just keep that in mind. They're really not considered full term till 38 weeks. Okay, but they define preterm labor between 20 and 37 weeks. So I want to make that differentiation. It's one of the most common obstetric complications. Therapeutic management. So risk prediction. Okay, have they had preterm labor before? Okay. Sometimes if it's our first baby, we don't know. Okay. So tocolytic drugs. So again, we use tocolytics. The tocolytics we use for preterm labor nowadays are going to be nifedipine, and we also use magnesium sulfate. So I'll go through this with you. There's not a first line drug, okay, for this. And we don't really ever keep people on these things long term, okay? It's mainly to prolong pregnancy for at least 7 days for the steroids to get in, okay? And it takes 2 full days for the steroids to take effect, okay? If we know they're going to deliver within 7 days, we want to give the steroids, okay? But they're given 2 doses, 24 hours apart. It's an IM injection. We usually give it in the gluteal muscle, and we keep the steroids in for 48 hours, and then we DC the magnesium sulfate. This is going to be the same as we would give for preeclampsia. It's the same loading dose, 4 to 6 grams, and then we run it at 2 grams per hour. Depending on their mag level, if they're subtherapeutic on the 2 grams, we can increase it. Sometimes we'll do it by a half a gram. Sometimes we can do it by a full gram. It just all depends. But the thing is we're trying to ward off labor until we can get the steroids in. And same thing as preeclampsia, but different effect, is we want them to be therapeutic. And it takes that's why we give the bolus, because we give a bolus so they can reach that therapeutic level quicker, because we're trying to shut them down. So it's not unusual to see women contracting for a little bit after the bolus, because we're waiting for it to take effect to reach a therapeutic level. And again, their mag level is going to be anywhere from 5 to 8. That's therapeutic. The lab is going to call you telling you they have a critical mag. But again, we want it to be in that range. Okay, but we don't want them to get toxic, but we want them to be in that therapeutic range. And that's why they get a lot of side effects from it. Nausea, vomiting, dry mouth, thirst. Okay, they feel terrible. They can't see correctly because it affects the muscles of the body. Okay, and so that's why we're doing mag levels on these patients, to make sure they're therapeutic and they're not toxic. We're going to give antibiotic prophylaxis. Okay, and the thing is what we're going to do is we're going to collect a Group B strep culture first, send that to the lab. That's going to take 2 days to come back. And in the meantime, we're going to start them on antibiotics. Okay, we're going to start them on Group B strep prophylaxis. Usually it's going to be in the form of penicillin or ampicillin. And then we're going to keep them on those antibiotics until we get that Group B strep culture back. Okay, if we're giving them ampicillin, it's going to be 2 grams every 6 hours, and they're just going to keep getting that until we get it back. Okay, So we talked about tocolytics. We want to educate the client. This is what we're doing. Psychological support, okay? A lot of times women feel lousy and they come in preterm labor. And you have to remember these patients, I mean, they're generally healthy. They just have a problem with the pregnancy. And so it's often difficult for them because they're thrown out of their whole routine. And the next thing they know, they're admitted to the hospital. And they have other children at home. They have jobs. They have pets. They have all these things going on. They may not have support. So we really have to look at all those things. So post-term labor. So this is pregnancy continuing past the end of 42 weeks. And I can't tell you I've seen anybody go that long, maybe 41 and 4 days, something like that. But for whatever reason, they don't go into labor. So I think it has a tendency to have dysfunction with Pitocin production, their own endogenous Pitocin, but for some reason it doesn't kick in. So maternal risk, cesarean birth, dystocia, birth trauma, postpartum hemorrhage, and infection. Some other things on this list too that I would tell you is they're probably more than likely not to have a very the labor is probably going to be dysfunctional, but the fetal risk, one of the fetal risk is also stillbirth. Okay, there's a 1 to 2% higher risk of stillbirth after 39 weeks. So they don't even have to reach 42. And the longer they go, that risk of stillbirth goes up. So when you think of post-term pregnancy and labor, you're thinking about placental function. The placenta can only last so long. So when it reaches this point in the pregnancy, it's not going to be functioning as well. It starts to shut down. So that's why all these effects occur, and that's why there's a higher risk of stillbirth. So baby, macrosomia, shoulder dystocia, brachial plexus injury, low Apgar's, post-maturity syndrome. This is kind of where they get cracked skin. Cephalopelvic disproportion, okay? Just because they're big. They keep putting on weight the longer they're in there. So nursing assessment, estimated date of birth, and this is why it's super important that we do accurate dating in the beginning of pregnancy, because we want to make sure, is this patient really post dates or not? Because we start talking to them about induction after 39 weeks. When they reach 40 weeks, we're doing antepartum surveillance. So they're getting ultrasounds to check for fluid level, and we're also doing non-stress tests twice a week, just to make sure that baby can tolerate labor in there. We have a lot of patients that don't want to be induced, okay? And so this can be a challenge because they want to wait until they're on their own. They don't really care how long it is, but we do have to tell them about these risks. And, if they have low fluid, we're going to recommend induction for the safety of the baby. So all this education is really important. Okay, intrauterine fetal demise. So there can be numerous causes. It can really occur at any gestation. The ones that are very devastating, they're all devastating, but when we get those term fetal demises, okay, these babies are full term. The patient usually will come in, they're not feeling the baby move, and they'll usually report this has been going on at least a day or two. Usually the patient knows, and then they just kind of make that decision to come in. But usually in a full-term fetus, you should be able to find those hard tones fairly easy. So if you're not finding those hard tones, a lot of times as nurses, when we've been doing this long enough, we know. It's like there's nothing there. There's no sign of life. It's like a hollow sound that you're hearing. Sometimes you'll pick up the maternal heart rate, but that's all you hear. So we do have to confirm with ultrasound, and then usually either the ultrasound tech will come or the provider really should be the one to come in and ultrasound that baby. And usually we take the probe, we put it right where the fetal heart is, and you can see no cardiac activity. Okay, it's a very sad situation. And so depending on the patient, usually they go through a labor induction just because it's safer. And if we don't have to do a C-section and cut her uterus open, we're not going to do that, okay? So they kind of go through this whole labor process like as if they would with a live baby, okay? And a lot of times what we do is we don't even put any monitors on them, okay? Of course, we're not going to put a fetal monitor on, but the contractions, maybe to see what they're doing and get them going. But if, we just induce them like we would another patient. And then we do assist them with the grieving process. We give referrals, like such as social services. We give them information about funeral homes if they want to have a burial or a cremation. We also can offer them momentums. So a lot of times we'll take photographs of the baby, we'll dress them up. Maybe they have clothes they want us to put the baby in. We take a lock of hair. You can actually make some really decent photos. I mean, it kind of depends on how long the baby's passed, but a lot of times they look like they're sleeping and they're pretty decent. We can do like a plaster of Paris and get their handprint and decorate that. We've done that. We've gotten handprints. So all those kinds of things we can do for the parents, just so they have keepsakes of their baby. Okay, uterine cord prolapse. Okay, so this is an obstetric emergency. Okay, it usually occurs due to ruptured membranes. It occurs at the time of rupture. The patient may spontaneously rupture. If they're artificially ruptured, most cases the provider is not using care and they're breaking the bag of water when the baby's head is not well applied to the cervix. If you think about the head being right against the cervix, there's no room in between there for anything else to fall through. So if the head is really high, like we talked about station, if it's like a -1 or -2, that's really too high to be rupturing that patient. And so they either need to give Pitocin to get the head more applied, or they need to wait. Okay, so we can cause those problems by not being careful. Okay, as providers. So it's a partial or total it's a partial or total occlusion of the cord with rapid fetal deterioration, because basically what happens is a fetal part is compressing the cord. So we want to prevent risk factors. We have to look to that polyhydramnios. That's a big risk factor. There's a lot of fluid. And a lot of times when these patients get ruptured, there's a big, huge gush, and the cord will wash down, okay, with the fluid. Continuous assessment of client and fetus, not nursing management, prompt recognition. Is your patient suddenly having variable decelerations they weren't having before? Or do they have a prolonged deceleration? Those are really good indicators that you need to go in and do a vaginal exam on that patient and find out what's going on. So you want to relieve compression. So basically you're putting your hand in. If you're checking them, you're feeling pulsation of a cord, you're going to lift that head off the cord. Whatever the presenting part is, it's compressing it. And you're leaving your hand in there until the baby delivers. Okay? So if you're having to ride on the bed back to the OR until that baby's surgically taken out, your hand is in there. Okay? So that's really what you have to do if you have a cord prolapse. Okay, placental abruption we talked about before when we talked about antepartum complications. So again, for review, it's an obstetric emergency involving premature separation. Risk factors, we talked about hypertension, cocaine. Okay, those are some big ones. Management dependent on gestational age, extent of hemorrhage, and maternal fetal oxygen perfusion. So it depends on the degree of abruption. And we measure these in a percentage, but we don't really diagnose them until after delivery, where the placenta is inspected. But usually if it's just a small abruption, baby usually doesn't look bad on the monitor, and we can kind of just wait it out a little bit, see if she can labor. But if there's a major abruption, like from a trauma, sometimes it's a complete abruption, and that's where the baby actually demises. Okay. If it's a larger abruption, we're going to be more emergent and deliver that patient more emergently. So we want to maintain maternal cardiovascular status, prompt delivery of fetus, cesarean birth if fetus is still alive, and vaginal birth if they're demised. Uterine rupture is obstetric emergency. We talked about this in the postpartum hemorrhage lecture. It is onset by marked fetal bradycardia, sudden. Again, you're looking at your strip. What's going on? What are the risk factors? Are they a VBAC? Okay, are they attempting a vaginal birth after C-section? Because this is the highest risk for uterine rupture. although it's very, very low if they have a low transverse scar. Sudden onset of fetal distress and other signs, a lot of times they'll have shoulder pain because all the contents from the uterus are going into the peritoneal cavity. Nursing management, prepare for urgent cesarean birth, continuous maternal and fetal monitoring. And that's another sign that you'll see is you'll lose the baby on the monitor, or you'll lose the contractions, or you'll go in and you'll notice the fetal station's really high, higher than it was before. So those are some signs. Okay, amniotic fluid embolism, this is also known as anaphylactoid syndrome. Okay, and so this is another obstetric emergency, exceptionally rare, but it is catastrophic when it occurs. And there's a sudden onset of hypotension, hypoxia, coagulopathy due to breakage in the barrier between maternal circulation and amniotic fluid. So what's happening here is essentially amniotic fluid and material in the amniotic fluid like vernix, meconium, hair, all these things get in the maternal circulation and cause an anaphylactic reaction. And the first sign you're going to see is respiratory distress. The patient is going to tell you they're short of breath and they can't breathe. And then what happens is this cascade occurs where they get hypotensive, cyanotic, they have seizures, they get tachycardic, coagulopathies, they go into DIC, pulmonary edema, uterine atony with subsequent hemorrhage, ADRS, cardiac arrest. And these patients code rapidly, okay? They code quickly. So unless you recognize what's going on right away, a lot of these patients don't survive this, okay? And a lot of times the baby doesn't survive either if they're still pregnant. So I saw one of these as a labor and delivery nurse. Actually, it was just a case that occurred while I worked there. I was off that day, but you always hear the stories. And the mom died. Okay, she died, but the baby, they were able to save. Baby went to NICU, but you have to kind of recognize what's happening. Okay, so this involves supportive measures to maintain oxygenation, hemodynamic function, and to correct coagulopathy. And they're usually in critical care. I think they do survive a little bit more than they used to. But again, you have to recognize that this is what's happening. Which of the following assessments would lead the nurse to suspect an amniotic fluid embolism? And your answer there is going to be A, respiratory distress. Okay, labor induction and augmentation. Now, before I go into this, there is in your required reading information about the Bishop score. You're not going to have to calculate it, but you're going to have to know what Bishop score is the cutoff for cervical ripening and use of Pitocin. Okay, so we'll talk about that. So induction, stimulating contractions via medical or surgical means. And so medical really means giving medications. Okay, and then surgical, we do use a Cook balloon that we put in the cervix to ripen it. And so we'll talk about that. Augmentation is enhancing the ineffective contractions after labor has begun. So indications that we might do an induction. It can be elective, but they do have to be 39 weeks. Okay, period. End of story. They have to have a documented ultrasound of the dates of pregnancy, because we can have prematurity. We talked about that in the preterm labor part. Prolonged gestation, prolonged premature rupture of membranes, gestational hypertension, cardiac disease, renal disease, chorioamnionitis, dystocia, intrauterine fetal demise, isoimmunization, and diabetes. So those are all mostly medical indications, but the elective ones, they have to be 39 weeks. So cervical ripening, and I want you to look at that Bishop score sheet. Usually a Bishop score under 6 are going to get cervical ripening agents, okay, which is going to be Cytotec, Cervidil, or a Cook balloon. That's usually what we use. Herbal agents, I kind of advise against that because there's no safety data on herbs. If they want to drink raspberry leaf tea, I tell them that's probably fine. I wouldn't recommend they do any of this until their term. Okay, and a lot of these things are not going to work unless their cervix is ready. Okay, so they want to try this stuff. I mean, to me, induction is induction. Some patients want to avoid Pitocin. They want to avoid Cytotec. or misoprostol or Cervidil. It's all doing this. It's all, the goal is the same. Unless you let your body go into labor on its own, you're doing something to try to get it going. Okay. Castor oil, if they really want to do it, it doesn't taste very good, but if they want to mix a tablespoon of it in and make a smoothie out of it, they can do that. Sexual intercourse is very effective because there is prostaglandin in the semen, so it does help soften the cervix. They can do breast stimulation or nipple stimulation. Hot baths I wouldn't recommend. They should really do, if they want to do a warm bath, that's fine, but hot bath, no. Enemas, we used to always give them. It doesn't really get them into labor. It just cleans them out. Okay. Mechanical methods, so we talked about that already. Pharmacologic agents, and then oxytocin. If they have a favorable Bishop score over 6, we'll use oxytocin. Otherwise, it's not going to do anything. If you give oxytocin and they're not ripe, it's not going to do anything. The only exception really is if they have ruptured membranes. We can't use any of those mechanical or pharmacologic agents like Cytotec or Cervidil. Okay, we just go straight for Pitocin if they're ruptured. And usually they respond to it because they have ruptured membranes. It takes them a while sometimes, but you can use like oral Cytotec, but you have to use a really small dose. And again, it's hard because, it doesn't absorb like it does vaginally, but it's something that can be tried. It's not unheard of. Okay, so assessment. Relative indications, gestational age determination. Again, we want to make sure they're 39 weeks unless they have a medical indication. Fetal status, maternal status, we're looking at Bishop score. Again, we want to monitor that baby for at least 20 minutes and have a Category 1 strip before we start anything. There's also a Pitocin checklist. Check that out in the required reading. I'm not going to ask you any questions on it, but I just want you to review that, just so you're aware of it, because it is a safety measure that a lot of hospitals have in their protocol before initiating Pitocin. And then pain relief and support. And a lot of this has to do with planning. Does the patient want an epidural at some point? There's a lot that goes into that. We have to pre-bolus them with a liter of fluid before we have to have their platelets back. Sometimes anesthesia gets busy. Is there a long list of C-sections scheduled? We want to try to get that patient's epidural in that time, or they're not going to get it, and then they're going to be miserable. Okay, so planning is really important, especially with pain relief and support. Is the following statement true or false? Oxytocin is an important agent used to ripen the cervix before labor induction. And the answer is false. We're not going to use it for a ripening agent. Amnio infusion. I talked a little bit about this in the fetal monitoring lecture. So if you haven't watched that lecture, go back and watch it. Indications of severe variable decelerations due to cord compression. This is the only reason we do it. Now on this slide it says thick meconium fluid. Okay, these slides need to be updated because this is no longer an indication. Your book says this. Your book is wrong. This came out quite some time ago. The school of thought was that it helped wash out the meconium so baby wouldn't aspirate it and get meconium aspiration syndrome. Well, that's not the case. Studies have shown that it doesn't prevent it. Okay, so throw that one out. We don't give it really for low fluid unless there's variables, okay? And we don't give it for placental insufficiency. It's only variable decels because you have to think about the etiology. We're giving it to replace fluid because of cord compression. Post-maturity or rupture of membranes, that goes along with variables. So we want to teach, monitor maternal and fetal assessment, and prepare for possible cesarean birth. And that's really if it doesn't work. Now, the thing with amnio infusion is we're giving these ladies anywhere from a 300 to 500 ml bolus. You want to make sure that you're checking that pad under her. This fluid's coming out, okay? You don't want to fill up her uterus and cause a uterine rupture. So you have to check it and document that the fluid is coming out, okay? So be sure and do that. And then we can run it usually at 100 an hour. But you do need a provider's order to hang an amnio infusion, okay? Is the following statement true or false? An amnion infusion is appropriate for a pregnant woman experiencing a prolonged second stage of labor. And that answer is false. We only give it for variables. Okay, vacuum or forceps or vacuum assisted birth. So it's the application of traction to the fetal head. These are some indications that we may use it. Prolonged second stage, non-reassuring fetal heart rate, failure presenting part to fully rotate and descend, limited sensation and inability to push effectively, presumed fetal jeopardy or fetal distress, maternal heart disease, acute pulmonary edema, intrapartum infection, maternal fatigue, infection. So there is a risk of tissue trauma to the mother and the newborn. So prevention as a key, but the thing is with this is they have to be a low enough station. If they can't see the head, they should not be applying a vacuum. Forceps, you can go a little bit higher, but vacuum, no. And really, the rule of thumb is you apply the vacuum, you turn up the suction to the green area, the provider pulls as the mother pushes. If that vacuum pops off the head, 3 pop-offs, and you abort the procedure. Okay, at that point, it's unsafe. And these can cause hematomas and significant hematomas. So we have to be really careful. The patient must be consented for a vacuum because they have to know there's risks. And they may opt to just go for a C-section if they know the risks. And this is kind of what the forceps look like. They can get marks on their little cheeks and everything from it. They can get like a bruise on their head from the vacuum. So if you're working in the nursery or you're doing an assessment on the baby, those are some important things to look at. So cesarean birth, classic or low transverse incision. Classic is not, they're not a candidate for a VBAC or vaginal birth after cesarean. The risk of uterine rupture is too high. So what we do is with the low transverse incision, we also call that a phalansteal incision. And with that type of incision, they can safely have 2 vaginal delivery. They can have 2 and have a vaginal delivery after. Okay, the risk of uterine rupture is less than 1%. Although a lot of providers don't like to do VBACs because they have to stay in house until the patient delivers and they just don't want the hassle. They're worried about liability and such. But it really is a safer option. It's better than having a C-section. Okay, the risks are much higher with operative delivery. Okay, so we always want to keep that in mind. Nursing assessment, history and physical exam. Usually you're going to follow them preoperatively. You're going to use the clippers to clip them. We don't shave them anymore because it does cause abrasions and then it sets them up for infection. And then we're usually giving them pre-op meds like antibiotics. We're giving them stuff to help empty their stomach. Anesthesia, we'll usually give them Reglan, Bicitra, and Pepcid. So those things are given preoperatively. We give them fluids, all of those kind of things. We want to make sure they're MPO. Most anesthesiologists want them MPO for 8 hours, and if they ate, they get bumped, okay? So we always want to ensure those things. And then we do post-operative care. Usually they're in the PACU for about an hour after delivery. The whole procedure usually takes about an hour, okay? And then VBAC, we talked about that already with that classical incision. So if they have an up-down incision or a T incision, they're not really a candidate for a VBAC, okay? And so usually you have to consent them when they come into labor and delivery that they know the risks of a VBAC. Okay, so we have to make sure. And then they're usually always continuous monitoring, and a lot of providers want an IUPC or intrauterine pressure catheter to watch those contractions. Also, cervical ripening is a contraindication for VBACs. So they basically need to go labor on their own. And then we can use low dose Pitocin a little bit to help them out, but we have to watch that too.